Good afternoon and welcome to HRStv. I'm Jeanne E. Poole, the editor-in-chief of the Heart Rhythm O2 Journal. Today I have with me Drs. Ram Amuthan and Ann Curtis from the Jacobs School of Medicine and Biomedical Sciences, University at Buffalo, New York. We will be discussing today the review article that Ram and Ann recently co-authored and published in our April issue of the HRO2 Journal. The title of this article is What Clinical Trials of Ablation Tell Us and What They Do Not. Also joining us today is Dr. Isabel Deisenhofer from the German Heart Center in Munich, Germany, to provide us the European perspective. So I think we'll start out with that. So Isabel, maybe you can lead off with a few questions that we can focus on the recent East AFNet 4 trial.
Yeah, thank you, Jeanne. And in fact, the East AFNet trial was a big deal in Europe because it was one of the largest European trials ever done in AFib treatment. It looked at patients that had AF lasting less than a year and had some comorbidities. And most East patients were actually then treated with antiarrhythmic drugs and a few with ablation. And the aim was to prove that early rhythm control was superior to conventional usual care. So, Anne, I have a specific question for you. In my feeling, it felt a little bit like this East trial was a sort of a proof for AF begets AF, because if you don't treat it right in the beginning, you will have that forever on, and you will have all the bad consequences of atrial fibrillation. What is your view of that?
Yeah, I think partly we do need to look at AFib burden and how much people are having early on, but I was very impressed with East AFNet 4 in that by treating them early, yes, there did seem to be a difference in outcomes. The other thing I was very impressed with is it doesn't just have to be ablation, right? You have to do something to keep the rhythm normal. And a lot of times early on when patients have paroxysmal atrial fibrillation, they are responsive to antiarrhythmic drugs, at least early. And so it doesn't necessarily mean one has to go straight to ablation. You can if you want, or if the patient wants, but it does mean that sort of ignoring it and hoping it won't develop into a bigger problem is probably not the right way to go.
Yeah, that was my feeling also, that it's not just a sort of a rhythm accident, that the first episode of AF, but should be treated. And another question was, and that was tried to be addressed also in East, and Ram, this question goes to you, was I had the feeling that it made a difference that the referral for this AF treatment was done to a cardiologist or even an EP specialist, and that was really important also in that trial.
I think it makes quite a bit of sense to send your patients with AFib early on to cardiologists or even electrophysiologists. You would expect electrophysiologists to be more aggressive in their management. And we now know that it doesn't matter how you maintain your sinus rhythm, as long as your patient is in sinus with whatever means possible, either through antiarrhythmic drugs or through ablation, you still get the results achieved. And so it makes a lot of sense to refer our patients with cardiovascular risk factors and early AFib to electrophysiologists so that we can be aggressive in our management of atrial fibrillation.
Yeah, if I could add to that, that's exactly the point, that when people go and have their AFib treated through primary care physicians, it's almost always rate control, right? Because they don't feel comfortable with antiarrhythmic drugs. And that was the control group in East AFNet 4, right? And they are the ones who didn't do as well, who were just treated that way.
Yeah. There was a lot of comparison also, at least here in Europe, with the AFFIRM trial. I remember a little bit how AFFIRM sent shockwaves through the EP community, at least in Europe and in my hospital. And everybody was like, oh no, it can't be that rate control is even maybe better than rhythm control, and what's that? And that's like a late revenge now that we see that rhythm control is better. What do you think, and what was maybe the decisive difference in these two trials? Why was rhythm control all of a sudden more successful? Was it really the antiarrhythmic drugs? Was it I don't know. What's your opinion?
That's a good question. I mean, I think a lot of people had thought that the reason AFFIRM turned out the way it was, or the way it did, was because the adverse effects of antiarrhythmic drugs offset the value of being in sinus rhythm. But I think the monitoring wasn't all that good. Remember, it was a rate control or a rhythm control strategy. So it wasn't that they proved that it worked. They put people on antiarrhythmic. And if you put somebody on an antiarrhythmic drug and it's actually not keeping a patient in sinus rhythm, you're getting the worst of both. You're getting the side effects of the antiarrhythmic drugs, and you're not having the rhythm control anyway. So I think it's the rigorous look at making sure that you get rhythm control that is the difference between, AFFIRM and the current trials.
And I'm just going to interject there, if you don't mind, because I think that when we look at CABANA, also there's a theme there, because CABANA, the drug therapy group, which was rate or rhythm, most of them were treated with rhythm control medications. If you look at AF burden, I mean, people had a significant drop in their AF burden, even with drugs. It's just that it wasn't as good as ablation. It wasn't nearly as good as ablation, but I mean, they still had an improvement both in the persistence as well as the paroxysmal AFib patients. I do think that, Anne, your point about careful monitoring and use of antiarrhythmic drugs, we've come a long way with knowing how to do that, I think, much more safely than in the AFFIRM era.
Yeah, and maybe also because the oral anticoagulation was continued also due to that monitoring in East. Right. And in AFFIRM, it was stopped in a lot of patients where people thought that their rhythm control strategy had worked, but as you pointed out, they didn't look at it.
Right.
If you look now at the CABANA trial, that's I think a completely different question. Also, the endpoints and the hypothesis in the trial is completely different. In Europe, it was quite nice to watch that most of Europeans thought that CABANA would never work, and were positively surprised that the endpoint was missed so narrowly. What was the US perception of CABANA?
I think some disappointment that it didn't turn out to be a positive trial. I think that's what people were looking for and hoping for, because beyond that, CABANA shows that ablation works better than antiarrhythmic drugs to keep people in sinus rhythm or prevent recurrences of symptomatic AFib. We know that, right? We've known that from multiple trials all along, whether it's cryoablation, radiofrequency ablation, and quality of life. So they got both of those, but that's sort of a Me Too type of thing. And then in the bigger consequences there, they didn't see as much. It's hard, I think maybe the difference to some extent, maybe the types of patients, because CASTLE-AF, which was a heart failure trial, did show, a benefit to doing the ablation. So it may be, if you take and I realize that CABANA did have patients had comorbidities in there, but if you take people who aren't quite as elderly or don't have so many comorbidities, it probably doesn't make a whole lot of difference whether you do an ablation early or not, right? Again, it's about following the patient and making decisions, not just once, but on an ongoing basis, but depending on how the patient's doing.
So I have a question. I've been wondering, Ram, maybe you've thought about this too. Is based upon the results of EAST and this discussion of antiarrhythmic drug therapy, is there a role for development of new antiarrhythmic drugs?
I think that certainly not many people want to undergo invasive procedures with ablation, so they might be offered antiarrhythmic drugs. And we have a lot of patients with advanced cardiovascular comorbidities in whom we are limited by the number of antiarrhythmic drugs that we can offer to our patients. So if we are able to find a drug which is less toxic or maybe is even specific to atrial arrhythmias, that is always still the case too. You could always make an argument for antiarrhythmic drugs. And back to the point about EAST trial, we know that no matter what strategy you choose, either it's ablation or antiarrhythmic drugs, as long as the patient is in sinus, you still do get mortality benefits. So I certainly think there is a point and a case to be made for the new development of antiarrhythmic drugs too.
So I guess back to Anne. So, with the results of EAST and the results of CABANA, how do you approach your patients? Do you come across really strongly saying that, ablation is going to be much better? How has this changed the way you think about talking to your folks?
I do think that you've got to look at the totality of the burden of AFib. And then the next question is going to be, how do you figure that out? And so, when somebody's having rare symptomatic episodes, I still think you've got a lot of different ways you can go. And it depends on the patient's tolerance for, unpredictable episodes, their willingness to go through an invasive procedure. So I think, you factor all of those things into it. I think if a patient is having a lot of asymptomatic episodes, I think it's something to factor into that, and maybe not feel so comfortable about leaving them alone, and maybe pushing them a little bit harder towards getting an ablation if it seems appropriate. In terms of the monitoring, I certainly don't think everybody needs an insertable loop recorder for this, but I think that there is a role for intermittent monitoring to make sure that you're not missing a lot of asymptomatic atrial fibrillation. And I even think some of the wearables, I say things like CardioMobiles or Apple Watches, if people are doing that on a daily or intermittent basis and just randomly catching episodes, or randomly recording their rhythm, I think it'd be awfully hard to think that they have a high AFib burden that you've missed. And so if we get some of that kind of monitoring, I think sprinkled in, along with knowing that generally speaking, a patient has symptomatic episodes, then it's the cliche is shared decision making, but it's talking to the patient about their tolerance for the episodes versus willingness to go through a procedure.
Yeah, Ram, on that sort of theme of monitoring, you nicely pointed out in the paper that the randomized clinical trials, by and large, have used the 30 seconds of AF for the primary output. A couple of trials were different, but most of them have used that. And of course, AF burden has become this sort of, interesting, popular way to talk about following patients. So how do you think we should incorporate AF burden into our randomized clinical trials? Should we be changing our endpoints? How would you approach that?
So regarding the AF burden, we know it's useful in certain populations. We for sure know that with reduction AF burden in patients with heart failure reduced EF, you do have a concomitant increase in ejection fraction and therefore an improvement in clinical outcomes. So in such patients, I guess it's reasonable to use AF burden as a measure of outcome. Now, outside that, I think the jury is still out on whether AF burden or an AF recurrence is helpful. We do point out that that is one knowledge gap that exists. So how should future clinical trials incorporate success of talk about success of atrial ablation? And we really don't have any data to support one over the other. We don't know if atrial recurrence is better, or we should be looking at it from a burden standpoint. And I don't know if Dr. Curtis had something to add on that.
Well, yeah, no, I think that's a great answer. I think AFib burden has to have an impact on cardiovascular outcomes, right? If someone has an extremely low AF burden, I can't imagine that it's going to make much of a difference in most endpoints, with the exception perhaps of stroke, because all you have to do is have one prolonged episode, and you could wind up with a thromboembolic event. But for things like heart failure and other endpoints, cardiovascular hospitalization, if your AFib burden is very low, so I think as an endpoint or as a goal of therapy, I think that's actually quite reasonable. And it makes more sense to me than a recurrence of atrial fibrillation by itself, especially if it's self-limited.
Yeah, I think from a clinical perspective, we already use AF burden one way or another. I think there's a lot of questions about it. We haven't adequately defined it. We don't know if it's duration, a combination of duration and number, or the pattern. So there's a lot to be yet understood about the use of AF burden. Well, we're going to wrap up here. So many questions answered, but so many more yet to answer. So I'm going to thank all of you for joining us today. I want to thank the authors for really a great review of this topic, and my colleague, Dr. Deisenhofer, for joining us today. And have a great day, and join us for further author interviews highlighting articles from the HRO2 journal.